First of all, there's a big prevalence of tuberculosis in many of the Western Asian countries, and diabetes is an up-and-coming, looming epidemic, if you like, globally, and particularly in the Western Asian countries. You think China's got a huge, China in fact probably leads the world in terms of the number of diabetes persons. You've got the South Pacific, which has a huge burden of diabetes, and you've got other countries scattered around, Indonesia, Philippines, again with a growing burden of diabetes as a result of urbanization, changing lifestyle, and a lot of tuberculosis. And I think where these two epidemics meet and overlap, then you've got a significant problem developing. It's a two-way system. Maybe I can start from the diabetes side. So if you have diabetes, the studies done to date in the world have shown that people with diabetes have a 2 to 3 times higher risk of getting tuberculosis compared with normal people. People often ask, why is that so? I think it's because people with diabetes have suppressed immunity. It's different from HIV/AIDS, but they cannot contain infections as well as normal people. And one of the infections they cannot contain is in fact tuberculosis. So both type 1, which is insulin-dependent diabetes, and type 2, which is the diabetes we're seeing all over the world related to overweight, obesity associated with high blood pressure, that also is associated with a higher risk of tuberculosis. The other way round, if you have tuberculosis, it can stress the system, and in stressing the system, your blood sugar level can go up. Now, in normal people, when you get onto TB treatment, that blood sugar level goes down and you're fine. But if you are prone to getting diabetes, it is possible that you stress the level and you go up to blood glucose levels that then stay high, and that you can then get diabetes. So I'm not saying that TB causes diabetes, but it stresses the system, and it may unmask diabetes in people who are sort of borderline, if you like. We've got a collaborative framework that spells out what needs to be done to look after patients with TB and diabetes, and this was produced by the World Health Organization and by our own organization, the International Union Against TB and Lung Disease. But what we really need is action, in fact, on the ground. And to make it very simple, I think in this region, if you have tuberculosis, you probably should be screened for diabetes. That means, in fact, asking patients questions: do you or do you not have diabetes? And if the answer is no, I don't have diabetes, not to take that as a no, because we know globally half the people living with diabetes on this planet don't know they have got diabetes, so they need to be tested. So in fact, with TB patients, if they say, no, I have not got diabetes, we should offer them testing. Now, it's a simple test, it's a blood test. And in fact, I'm afraid it's 2 blood tests. You normally do what we call a simple random blood glucose test. And if it's above a certain level, that person is at risk of diabetes, and they have to come back to the clinic in a fasting state to have what's called a fasting blood glucose. And if that's high, then you say, listen, you have diabetes and we need to treat you accordingly. So I think we need to do that. We need to do that all over. The only country I know that has made a policy decision to say we must screen all TB patients for diabetes is India. I qualify that. I think some of the South Pacific islands have also made a policy decision that if you come in with tuberculosis, you will be screened for diabetes. Looking at it the other way around is quite difficult, because TB is a very important disease, but actually it's an uncommon disease. You know, we talk, for example, about, say, a rate of 300 cases per 100,000. Well, actually, that's not many, but nevertheless, to us, it's a problem. So it does mean you have to be a little bit careful. We probably would advocate in diabetic clinics that if your country has a high prevalence of tuberculosis, it's worthwhile screening for TB. But we've encountered problems here, Bobby. So diabetes doctors don't want to do this. It's extra work. They don't want to have to record it. I can understand that. I can understand that. And they may say, what's the point if I screen 200 people with diabetes and I pick up one case of TB? What is the point of doing that? However, we've done work in India and in China showing that if you look at this, if you go to diabetic clinics, you screen routinely for tuberculosis, you pick up much more TB than you do in the normal population. So this is a worthwhile thing to do. And the other reason I think it's worthwhile thing to do is that, you know, if you look at the WHO TB reports, every year we miss 3 million TB cases. There's 9 million cases every year estimated. We diagnose 6 million. Where are the other 3 million? So we need to go to the hotspots where these people may be. And sure as eggs, one of those hotspots, it's not a huge hotspot, but one of the hotspots are the diabetic clinics. So I think we need to be active here and do this, what's called bi-directional screening. So we need to put action into our mouth. You know what I mean. The question of how do we screen diabetes people for tuberculosis, and maybe what we've done in India and China, very simply, is not to mention tuberculosis, is to say to a patient, are you coughing? If they say, yes, I'm coughing, say, well, how long are you coughing for? And if they say, well, I've been coughing for 2 or 3 weeks, that makes those people a suspected tuberculosis case. And then you need to take it further. You need to ask if that person has lost weight, if that person is having fever, if that person is having night sweats. And if the answer is yes, 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 then it is much better to diagnose tuberculosis early than wait for it to develop and cause substantial problems. You know, there's still 1.5 million people die every year from tuberculosis, and they should not die from tuberculosis. You know, we have the drugs to cure this disease. So it's because people are reluctant, healthcare workers are reluctant to push forward on this, I think. In fact, there's 2 big publications coming out. I've seen them, but they're not yet out in the New England Journal of Medicine. They're what's called online. There's the START trial and there's the Temprano trial from West Africa. Now basically both of these trials showed that if you are infected with HIV and you start antiretroviral treatment as soon as you've been diagnosed at a high CD4 count, in fact this prevents you developing AIDS, prevents you dying, and it protects you against getting tuberculosis. So that was a big message to me. So I think this is very important. We've known all along that in someone living with HIV, antiretroviral treatment is a good protection to stop that person getting tuberculosis. We've known that if you have a very low CD4 count, your immunity is suppressed, that ART is very good. It brings your immunity up, and as that comes up, you get more and more protected against getting tuberculosis. We've also known that at higher CD4 counts there's a protection, but what START and Temprano have clearly shown is that basically as soon as you're diagnosed with HIV, at a very high CD4 count, ART will protect you against getting tuberculosis. But I'd like to qualify it. It does not protect you 100%. It does not give you the same protection as somebody who does not have HIV infection. And so myself and various other colleagues have been pushing for the fact that with antiretroviral treatment, we should seriously be considering isoniazid preventive therapy. Now, isoniazid is a TB drug, and normally when you treat tuberculosis, you must give 3 or 4 drugs or more drugs together to stop resistance. But here what we're doing is we're giving one drug to maybe kill off a few bacteria inside the body, or to protect that person from getting TB if he inhales the TB germs into the lungs, and so it will kill them off at an early stage. So one drug is okay for that. And I think the Temprano study, and there was another study published last year in South Africa, I call it the Rangaka study, but Rangaka was the chief principal investigator, showing that if you are HIV infected, you're on antiretroviral treatment, if you add isoniazid preventive therapy in, that further protects you from getting tuberculosis. It gives you added protection over and above antiretroviral treatment. And you know, it strikes me always that you have an ART clinic where essentially you're on treatment for life. You have to come every 1, 2 or 3 months to be checked, to get your drugs and to continue. And unfortunately at the moment there's no cure for AIDS, so this is treatment for life. So it's very easy to me to introduce isoniazid preventive therapy into this. People have said, oh, it's difficult to follow up patients. You've got a structure. One of the things we don't know is how long we should give isoniazid preventive therapy for. In sub-Saharan Africa, southern Africa, where there are very high rates of TB, very high rates of HIV, it looks like you should probably give it for life. So, interesting. So, antiretroviral treatment for life and maybe isoniazid preventive therapy for life. Now, obviously, you have to be a bit careful. Isoniazid is not completely non-toxic. Some people can get some liver problems, so they have to be monitored. But again, the antiretroviral clinic is a place to monitor people. You come back regularly for checkup, and all patients know if they develop side effects, they come back. So I think we've really got to think about this. We've got to now, from start in Temprano, get people onto treatment early. I'll be interested to see what WHO says in their new guidelines about this. A lot of people have been hammering test and treat, which means get tested, positive, start treatment. Completely different to 10, 15 years ago when we used to wait a long time. And the reason for changing is that we have much safer drugs, much easier drugs to take now. One pill once a day, pretty free of side effects, it's fine. So, you know, you can start people who feel all right on this treatment. So I'm very encouraged, Bobby. I think this will be, I think these are two very important studies, and they supplement the study which I think we talked about 2 or 3 years ago, HPTN 052, showing that at high CD4 counts, if you give antiretroviral treatment, you reduce the infectiousness. So therefore you stop that person transmitting to someone else. So I think now we know that ART at a high CD4 count not only stops you transmitting to someone else, it's also good for your individual health. That's great news. So I think very encouraging.